This Society for Hematopathology video tutorial is presented by Dr. Michael Bayerl, who is Associate Professor of Pathology and Hematopathology Fellowship Program Director at Penn State Medical Center. Dr. Bayerl would like to discuss the evolving topic of small B-cell lymphomas with plasmacytic differentiation in lymph nodes.
So today we have a lymph node from a 55-year-old man who has bilateral axillary lymphadenopathy. This is an outside consultation case. I have no idea if the bone marrow is involved or whether the patient has splenomegaly. First of all, we can see that this lymph node is partially effaced. It's vaguely nodular, but some of the nodularity to me looks like it's that nodular paracortical moth-eaten pattern rather than the effacing infiltrate. The infiltrate that's effacing the node seems pretty blue and pretty diffuse. Now let's take a look at the cytology of the infiltrating cells. So the first thought that crosses my mind is they're small cells because on low power they're predominantly blue. We come here and that theory is confirmed. We have mostly small lymphocytes, mostly round, perhaps slightly irregular, very condensed chromatin, inconspicuous nucleoli, little chromocenters. And the thing that strikes me is that there's virtual absence of large lymphocytes. There may be one here, but even that's only about the size of the histiocyte nucleus. So, to my eye, this is an extremely monotonous proliferation. And there's very few things in lymph nodes, benign or malignant, that are truly monotonous. Another finding we see here in this lymph node is hemosiderin in macrophages. So that's something we might frequently see in lymph nodes from the axillary region. And now we're going to take a look at another area. A lot of it's around these sinusoids. And what we start to see is plasmacytoid differentiation of cells. Here's some eccentric nucleus, amphiphilic cytoplasm, perinuclear Hoff. We start to get some clock-based nuclei in here too. And as I alluded to previously, this case was seen outside and they sent flow cytometry to a reference laboratory and got the generic flow cytometry report, which is a monoclonal B-cell process with light chain restriction, but not expressing CD5 or CD10 with a long differential diagnosis. The architecture is that of a very monotonous process. It has partial effacement of the lymph node, preservation of sinusoids in some areas, a little bit of hemosiderin, some plasma cells in there, which we'd like to know whether those are clonal plasma cells or benign plasma cells, whether they're part of the tumor or not. And our differential now, assuming that we don't have one of the oddballs, is really the marginal zone lymphomas, lymphoplasmacytic lymphoma. We'll start with our typical T-cell stained CD3, and we see that it's a paucity of cells, perhaps negatively highlighting some rounded structures which might be follicles that we may not have appreciated from low power. From the CD43, which nicely highlights the areas of nodular paracortical hyperplasia, so that confirms our impression. But the majority of the cells, particularly the paracortical cells and the cells infiltrating outside the lymph node, seem to be negative. This is a CD20. Again, the cells infiltrating the fat are CD20 positive B cells, as we would expect from the flow cytometry. And we see that there doesn't appear to be co-expression of CD43 on our CD20 positive cells. This is a BCL6, and it very nicely shows a few preserved follicle centers, but the vast majority of the cells are going to be negative. Interestingly, this is a CD21, and I think it very nicely highlights that there's a large number of small follicular dendritic cell meshworks. They're fairly tight in some areas over here where we saw the benign follicle, and some of the other ones look fairly disrupted. And basically what is going on here is that those small monotonous cells are colonizing the follicles, just like we would see typically in a marginal zone lymphoma. Next, let's look at the plasma cell component. Here's the CD138, and it does show plasma cells, perhaps in a perisinusoidal pattern. So this is in situ hybridization for lambda. We see a few positive cells. And then here's the stain for kappa RNA. So clearly we have a restricted population of kappa, which was the same light chain as the outside flow cytometry had reported. So we're fairly certain now that the small B cells, monotonous population, and the plasma cells are related. Going back to our original observation that we see that most of the cells are very monotonous and that most lymphomas are not truly monotonous. Monotonous small B cells are mantle cell lymphoma until proven otherwise in my book, even if they're CD5 negative. So I did a cyclin D1, which has nice internal control here with the endothelial cells, but the tumor cells are quite negative. And because I didn't want to miss a cyclin D1 negative mantle cell lymphoma, I did actually go ahead and do a SOX11, and it was negative. And now, just for completeness sake, when we think about small B cell lymphomas and leukemias, obviously CLL is by far and away the most common disorder. The flow cytometry here would be highly against it without a CD5, but I did take the liberty to do a LEF1 stain, LEF1, and that can be positive in the vast majority of CLL cases. In this case, it's really only staining those T cell areas, again showing the paracortical hyperplasia areas, but as we get out into the infiltrating tumor, it's clearly negatives. So with our case, our differential diagnostic considerations really were lymphoplasmacytic lymphoma versus the other small B cell lymphomas that can have plasmacytic differentiation, and in this case, perhaps nodal marginal zone lymphoma. So in order to resolve that, I went ahead and ordered a study for MYD88 mutation, and in this case had a very obviously positive L265P MYD88 mutation. So typically, classical lymphoplasmacytic lymphoma was described as a lymph node with overall architectural preservation, subtle paracortical infiltration by small cells, very monotonous, dilated sinusoids rather than effaced sinusoids, and then of course plasma cells frequently with Dutcher bodies, increased mast cells, and hemosiderin in the lymph node. What has become clear over time is that there are other small B cell lymphomas that have MYD88 mutations along this spectrum. And basically, if you have an MYD88, the spectrum of those small B cell tumors and their architecture predominantly is maybe expanded into what's called an atypical histology. And what this means is you may have architectural effacement rather than preservation, like we saw in our lymph node, infiltration outside of the lymph node. You're allowed to have follicular colonization or even progression to some larger cells. In contrast, though, there are tumors that historically would have been called polymorphic lymphoplasmacytic lymphoma and some other lymphoplasmacytic like gamma heavy chain disease cases that would be negative for the MYD88 mutation, and those are actually excluded. What this means is truly monotonous small cells with plasma cells is what we're really looking for at a cytologic level. Some work done by a group at Mayo Clinic as well as down at University of Arkansas has shown that flow cytometry can be helpful to tell lymphoplasmacytic lymphoma from primary plasma cell neoplasms, because in plasmacytic lymphoma you'll see a proliferation of plasma cells that are still maintaining their CD45 and 19 expression. So typical lymphoplasmacytic lymphoma cytogenetics, we can see some non-specific and non-entirely sensitive changes, including deletion of 6q, which seems to be associated with the bone marrow predominant presentation of the disease, and trisomy 4. So next generation sequencing identified the MYD88 L265P mutation, which is present in the vast majority of lymphoplasmacytic lymphoma, particularly those with IgM. In the context of small B cell lymphomas with plasma cells, the positive predictive value of that for lymphoplasmacytic lymphoma is actually fairly large, particularly if we accept the atypical architecture. MYD88 265P is not specific because it's seen in other tumors such as non-germinal center diffuse large B-cell lymphomas, particularly cutaneous primary large B-cell lymphoma of leg type, and in immune privileged sites, including primary CNS and testicular tumors.
For an in-depth discussion about small B-cell lymphomas with plasmacytic differentiation, the Education Committee recommends the references listed on this slide. Thank you, Dr. Bayerl, for your contribution.